All right, everyone, we're going to go ahead and get started. I'm going to be popping in and out, sharing the screen a lot. Brandy, I have the Word document as well. So is that what you want me to share first, or the PowerPoint?
PowerPoint.
PowerPoint, all right.
I see Lisa Emery is here. Good morning, Lisa. Okay, so today we're going to be talking about COPD exacerbation. Today is a little different from our usual hub-anchored presentations. We have wonderful presentations from Dr. Stansbury, Dr. Sharma, Dr. Sangani, Dr. Sela, who are wonderfully referenced and usually include an up-to-date review of the literature on the topic they're discussing. Today is three voices from the field. Less academic, but kind of pearls from people who are out doing practice. We have Brandy Bell from Lincoln Primary Care, Southern West Virginia Health Systems. We have me from Fayette County, and we have Chris Tipton from Logan County, Southern West Virginia Health Systems man, and two of his colleagues. Hopefully he'll be here soon because he did a lot of work to prepare this presentation. Two of his colleagues who he works with there at MAN, Sheila Morgan and Johnny Mullins, are also with us. So that's great. Another thing about today is it's kind of a mnemonic day because we have three mnemonics. So I hope you guys love mnemonics that relate to important issues in COPD generally and COPD exacerbation. So if you would go ahead and do the next slide, Elizabeth. So I have nothing to disclose. Chris Tipton, nothing to disclose. Interestingly, Chris is one of the two physician assistants on the West Virginia Board of Medicine. We're using mainly the GOLD guidelines, which are pharma financed and controlled, but they're the best thing we have for a COPD guideline. And so we use it, just keeping in mind the source. Go ahead. So this is, so Brandy, I'm showing this, and I think what I might do is let you take it from here. This is a slide actually that Dr. Allison Sela used at our last echo. And this always used to befuddle me and confuse me as a medical student. I just had a hard time getting it and remembering it. So Brandy, take it away.
All right, so you can Google like lung volumes chart, and you're going to get a variety of how they're set up. So the mnemonic that I use won't pair well with this chart, but I did send the chart as a Word document, I think. So if you'll pull that up for me, I'll just take a couple minutes to go over the mnemonic to help everybody remember this. And Johnny's probably familiar with it. It's something that we learned in the PFT Kettering course like 2 years ago. Okay. And if you'll just scroll down a little bit for me, up just a, okay, right there's fine. Go all the way down to the bottom and I'll read off what the mnemonic is, and then we'll go back up to the chart. Okay, so the mnemonic is going to be: the loving couple went on vacation in an RV. They ate fried chicken and ice cream. Irv is watching TV with Irv in the RV. And then if you'll scroll back up to the chart, you're going to start on the right side and you're just going to go up. So it's going to be TLC, total lung capacity, which in short is going to be the loving couple. Okay. And then you're going to go down. Went on vacation, which is vital capacity. So think VC, vacation, VC, vital capacity, in an RV, which is residual volume. And then you're going to go back up again. They ate fried chicken, which is FRC, and ice cream. And then you're going to go back down that last row. And this is where you can mix it up with Irv and Irv, but you're going to know your inspiratory and expiratory. If all you need to remember is your inspiratory and expiratory side, you'll know that Irv is watching TV with Irv in the RV. And that's my little pitch. But it's a really easy way to remember it.
Okay, Brandy, so go down. I want to see, Elizabeth, go down so we can see. Okay, so the
Yes.
loving couple, TL, total lung capacity, went on vacation, vital capacity,
Yes.
in a RV residual volume. They ate fried chicken, functional residual capacity, and ice cream, inspiratory capacity. Inspiratory reserve volume is watching tidal volume with expiratory reserve volume in the residual volume.
You got it.
All
This
right.
honestly helped me, because if you're taking the PFT board exam, they will ask you questions about, they'll give you different volumes and then be like, which volume's incorrect? And if you don't know this chart, there's no way you can figure out the answers a lot of times.
Cool. And you sent it out the last time. So I think if you put it in the chat, or somebody puts it in the chat, Elizabeth, I can just attach the file in the chat, the Word document file. And so if
Yeah,
people,
I'll actually could just attach that to the recap portion so you guys can have everything together.
okay, great. All right.
Thank you.
So thank you very much. Any questions about this or any comments?
This is not my own. This is bettering.
Yeah.
But
yeah.
I like it a lot.
Copyright Brandy Bell.
No.
All right, Johnny and Sheila, keep working on Chris. We don't see him yet, and we're gonna need him. Okay, back to the PowerPoint, please, Elizabeth. So move on. So that was the lung volumes mnemonic. Next slide. So I hate to present Chris's case, but I think we need to go ahead and present this case. So if you can put up the case, Elizabeth, please. So this is a case that Chris Tipton of Southern West Virginia Health System Man submitted. Johnny, can you say a little bit about who Chris is and what his role is there at Man?
Sure. Chris is basically, obviously, he's a PA here, a provider. He probably, I tell you, this poor guy is so busy. If you're a patient and you're trying to get in, you're looking at about a 3 to 4 month, ahead of time kind of visit. He's from this area. The local people just love him. I mean, he takes care of the football team, the basketball team here, stuff like that. Just as far as his personal life goes and stuff, he has, what, 3 kids? 3, I think they're all boys, aren't they? All boys. Right now, one of them is in wrestling at school. I mean, he has family in Denver. That is kind of his personal life. On the other side of it, professional, he is somebody that has spoke at gosh, what was that thing that he recently done at Greenbrier?
I don't remember what they call it, but I know he did it. He speaks on everything.
I honestly, when I talk to him about things that I say, what do you do just in your off time? It's mostly reading about pulmonary issues. That's his hobbies and stuff like that. And I just admire him so much. I think when it comes down to it, we have, pulmonologists around here and everything like that, but you can't beat him in so many ways. And that's basically my view on Chris Tipton. He's just
Thank you. That was my sense from what you had told me before. And Chris thought a lot about different cases and came up with this case. So this is a 56-year-old man, disabled coal miner. Go ahead and skip over the PFTs there because we're going to show them on the regular format. Keep going. 56-year-old man, severe COPD, presented to Chris, and so Chris had seen him many times before, but on this particular occasion, which was a few weeks ago, presented to the health center with severe, already had severe COPD, but had increased shortness of breath, non-productive cough, already depended on oxygen 3 liters a minute. Known also has comorbidities of coronary artery disease and atrial fibrillation. Interestingly, he had a history of 1 out of 2 cystic fibrosis genes found in 2008, but sweat chloride test was negative. Go ahead down. Also, alpha-1 antitrypsin testing showed a phenotype of MZ, and he had actually been on replacement treatment, but wasn't able to tolerate it, so it was stopped in 2014. Had a normal cardiac catheterization in 2021 with an overall ejection fraction of 60 to 65%. Right ventricle mild to moderately dilated. You can keep going down to comorbidities. Had quit smoking 20 years ago. Before that, had smoked a pack a day for 10 years. You can see the family history. One thing is that he's very thin, had a low BMI. And one acronym that I would like people to think about during this case, another acronym is BODI. There's something called a BODI index that we use to identify really prognosis for people with severe COPD. And as some of you will recall, the BODI index is made up of the dyspnea level, the FEV1% predicted, the 6-minute walk test, and the MMRC. So as we go through this, I'd like you to, oh, wait a minute. And it's also, oh, wait a minute, BMI, MMRC, FEV1% predicted, and MMRC. This patient's usual MMRC was 3, and his 6-minute walk test was 700 feet. So if there's anybody out there who wants to be calculating his BODI index as we go through at the end, you can tell us what it is. And maybe tell us a little bit about it. If anybody wants to take that on in parallel to the presentation. Just go back up a little bit, Elizabeth. On physical exam, as you can see, he had a BMI of 17, weight 118, blood pressure as noted, heart rate 99, respiratory rate 20 on 3 liters with a SAT of 97%, was using accessory muscles to breathe. Notice it says clear lung fields. And what that means in this case probably is very diminished breath sounds. Can't hear much of anything because of his severe emphysema. Non-productive cough, temp 97, no edema, no clubbing. He had an EKG which showed rate-controlled atrial fibrillation. And Elizabeth, let's go ahead and put up his chest X-ray. Chris, sent us an image of that. And so anybody want to talk, anybody want to volunteer to talk about this chest X-ray? Johnny, Lisa, Brandy, what you see?
Doc, I'm sorry, I was off most of last week. My wife tested positive Tuesday and I went off Tuesday as well, but had all the symptoms and stuff like that, but didn't test positive. And so I pretty well know nothing about this case because I was gone.
So you pass. Anybody else? So what you see here is a typical emphysema chest X-ray with very low diaphragms, hyperexpansion of the lung fields, Chris mentioned to me that there were bullae here. In other words, big air pockets. Honestly, I can't see that, but if you could, they'd likely be in the upper lobes. And a lot of increased markings in the lower lung fields. Some scarring at the costophrenic angles. You can see the costophrenic angles where the chest wall and the diaphragm meet on the sides are not nice, sharp, and clear. So pretty much anybody would look at this and say it's an abnormal chest X-ray, severe COPD with low diaphragms. So thank you, Chris, for that image. And then if you could please put up, Brandy, his pulmonary function test. There we go. Okay. And can you click on that plus button at the top there and make this a little bit, see if you can make this a little bit bigger. Good. Keep going. Okay, so you can see there his values that his, let's just look at his post-bronchodilator numbers. His FVC was 1.49, which is 36% of predicted. His FEV1 is 0.49, 16% of predicted, and his FEV1 FVC is 33. So he definitely has obstruction. And if you remember the gold guideline of 80, 50, 30 for calculating the severity based on the FEV1% predicted after bronchodilators, this is in the very severe category. It's below 30%. There are no significant changes post-bronchodilator. We don't have lung volumes or DLCO here. And interestingly, if you just scroll up a little bit, we also don't have comment by the technician about acceptability and reproducibility, which is something that we would like to have.
I think with this one, Dr. Doyle, you see the barcode, Elizabeth, if you'll scroll right above the barcode, there's a pre-post, it just says met the requirements. This is the device we had before we upgraded a couple years ago. But it did say he met the pre and post as far as reproducible and reliable. I think it had to be A or B on this system, right, Johnny? Before it would say they met the standards.
Yep.
Okay.
You mean there should be a letter A or B there where it says met?
No, this particular program did not give a letter grade. It just either said met or not met the standards. But I think A and B, maybe C, was considered met the standards. So it would just say met or not met.
Okay.
Okay.
Thank you. Thank you. And do you think,
Sure.
when you look at this, do you think that this is a spirometry done by a respiratory therapist, or who do you think would have done this?
This,
Yeah.
Johnny, was this you or Sheila maybe?
It most likely is. I have, like I said, I don't even know the name of this patient, so I wish I could give you a little more of it. That's what I was looking for this morning when I came in, was some paperwork to kind of help guide this through, and I don't have any. So I wished I could help you. It does, I mean, like she said, that program particularly to me was an older program. It's the way that they done it was kind of cut and dry. It was just whether it met it within those percentages or not. And even with the pre and post up there at the right, you can see where it says good effort, blast out faster, good effort that way, with quality messages and stuff. The new programs that we have in this new computer, man, it's awesome. And really and truly, when I'm looking at this as a respiratory therapist, or even Sheila, I'm sure we're just salivating over the fact that we'd like to get this person in and do a new one on the new machine. Because yeah, we'd find out a lot more, I think.
Okay.
There's not even a DLCO or an MVV done on this, obviously, you can see. So, yeah, he needs more.
Another way to say that is that there has been progress at MAN in terms of equipment and quality of PFTs. All right, if you can go back to the PowerPoint, please. Okay. See, we got Cabin Creek here, but still no Chris, who did a lot of work on presenting this case, or preparing this, by the way. All right, so basically you got this 56-year-old man with severe COPD who presents to the health center with worsening shortness of breath, non-productive cough, and this echo from the field is about acute exacerbation of COPD. And so everything here says that this patient has an exacerbation of his COPD. Go to the next slide, please. I think we went backwards, maybe. Keep going. So the next thing that we want to talk about is when you have a patient with an acute exacerbation, to think, what else could it be? And that's really, our next mnemonic here in a second, is to give you something that you can have a checklist either on the wall, pinned on the wall, or in your head, or in a sticky note somewhere. But it's very common for us to see patients with acute exacerbation in the breathing center who come in for pulmonary rehab, but they're not feeling very well, come in for a breathing test, but they're feeling worse, or just come in because they know you and they know that they can walk in and talk to you. Whereas if they call up to get in, sometimes it won't be till tomorrow or the next day, depending on where it is. So it's really important for us, the respiratory therapist group, to say, gee, Mr. Jones has an exacerbation. I'm pretty sure that's what it is, but what else could it be? And here's the table from the Gold Report 2022 of differential diagnosis of COPD exacerbation. And they have 6 things here. Pneumonia, and the way to check for that is with a chest X-ray, and they say C-reactive protein or procalcitonin. Well, that won't help us because those won't come back till tomorrow or the next day. So we're going to generally judge this based on fever, lung sounds, chest X-ray, how much trouble the person is in. And there can be, in a way, pneumonia can be an exacerbation of COPD, a more severe exacerbation. Next one is pneumothorax, and that's a really important one. And interestingly, this patient has emphysema with bullae. And so if one of those bullae ruptures, that would give him a pneumothorax. So pneumothorax is really important to always keep in mind. That's why you need this checklist, because that's something that could require chest tube hospitalization. Next one is pleural effusion. In other words, a collection of fluid in one of the lung fields. The commonest reason for that is heart failure, but there can be other causes of pleural effusion, including malignancy or infection, unresolved pneumonia or infection. If there's a big pleural effusion, you can diagnose that with percussion. Most people don't feel confident to do that, but if you get in the habit of percussing lungs, especially someone like this who's going to have sort of really hollow sounding lungs, you can find dullness, over a lower 1/3 of a lung field. It needs to be a fairly large pleural effusion, but usually the way we diagnose this is with chest X-ray or ultrasound. In some places, and ERs, more and more physicians are using ultrasound themselves as a diagnostic tool, almost like a more fancy stethoscope. The next one to think about is pulmonary embolism. And especially patients like this with coronary artery disease, atrial fibrillation, they're at increased risk for clotting. This patient, that's something to consider. You can use a D-dimer to rule that out if you have it available right now. The ER has that available right now, but you might not have it till tomorrow. So this is a tricky one. A recent study showed that 6% of patients admitted to the hospital for COPD exacerbations had pulmonary embolism. So think of it, and probably if you're concerned about it, where you are in the health center, out in the country, probably what you're going to have to do is talk to one of the providers about it. The next one they have is pulmonary edema due to cardiac related conditions. And in this case, pulmonary edema, it can be acute and severe. Usually people will have wheezing over the lung fields when they're in acute pulmonary edema. But pulmonary edema can also be interpreted as something chronic. So we would say CHF, chronic heart failure. You have to think about heart failure when you have somebody with COPD who comes in with worsening breathing. And in fact, one of the commonest situations we find ourselves in with an older person with both COPD and heart disease, like this patient has, is we're asking ourselves, is this worsening of breathing, is this worsening of dyspnea mainly due to his lungs, or could it be due to the heart? And we have to sort that out. We have a BNP, we have the D-dimer, we can do the chest X-ray, listening to the lungs, checking for fluid overload, like with a jugular venous distension. There's a number of ways, but if we are really concerned about acute heart failure, that patient is probably going to need to be in the hospital. And the last one on their list is cardiac arrhythmias, like atrial fibrillation, atrial flutter, and you should usually be able to tell that by auscultation and then by doing an EKG. So that's the 6 that the Gold Report lists. So we're going to give you a mnemonic for this. Next slide.
Dr. Doyle, I think that Chris has joined us. I just wanted to make you aware. I think on John, is that you, Chris? On Johnny's camera?
Sorry.
Oh, no worries. Thank you for coming.
Oh, great. Welcome, Chris. Well, you're not too, we did the case, but we haven't done any of your slides or any of your discussion. So you're good.
Okay.
Okay, next slide. So here's a mnemonic. Here's a checklist mnemonic for you got a patient with COPD, they come in, their shortness of breath is worse. The mnemonic is C3PO4, where the O is a 0, C3PO4. So if you think of 3 C's and 4 P's, we added 1 here. And that one is compliance, which is a word I don't really like, but when someone with severe COPD is worse, has worse shortness of breath, a common reason is they're either using their meds or their inhalers wrong, or they don't have their meds. They're out. And so remember that possibility. And the respiratory therapists are really good at talking to patients about how they're using their medicine, whether they have their medicines. So C3PO4, 3 C's and 4 P's is cardiac heart failure, cardiac arrhythmia. So these are pretty much the same as the gold ones, only packaged a little bit different, hopefully to make it easier to remember. So number 1 C, heart failure, number 2 C, arrhythmia, number 3 C, compliance, not having their medicine or not using it properly. And the main medicines, other than the oxygen, are inhalers. So very often the problem is not having the inhalers, being mixed up about the inhalers. The pulmonologist prescribed a new one, but they aren't exactly sure how to use it. that's a really important one to check on. And then the 4 Ps are the 4 Ps of the GOLD: pneumonia, pulmonary embolism, pneumothorax, pleural effusion. When someone comes in with an acute exacerbation, always ask yourself, what else could it be? And go down the C3PO4 list. And next slide. And Chris, you can pick it up from here.
Okay. Well, I guess once we went through the whole standard, you know, I wanted us to make sure that we did certain things. So I was really just wanting some discussion here, like the MRC Dispute Scale. So if we looked at this, now he had a study where we actually did a walk test on him about a year ago, and he actually could walk 720 feet. And he did okay with that, but you know, he struggles pretty much on a daily basis. So if we went through the MRC scale, where would we rank this guy? Where would we think he would be?
You
Well,
can
we know
unmute or, sorry, raise your hand, unmute. Please feel free, like Chris had discussed, we want to make it a discussion. Thank you.
well, he actually, every time we ambulated him, he actually had a period of dyspnea pretty much from onset, but he pushed himself. He's not very active. He's a guy who just struggles through life pretty much. Now he goes on and off of oxygen to some degree, but I would say that he would probably think, you know, he was at least a mild to moderate on his ambulation normally, with any activity at all. Now he did get easily exerted, you know, any kind of shortness of breath. I would say he's pretty high, and that's a normal thing for him. That's not something that would that changes daily, especially when it exacerbates. It just makes him that much more severe. Any questions on that?
Yeah, I have a question. What are you calling his MMRC?
Yeah, that's a good question. So what do you guys call it? What do you think you call it?
This is Brandy Bell at Lincoln Primary. I would probably give him a 3 if, you know, in 6 minutes he could only walk 700 feet. You know, he take a couple breaks, because I think 3 is the one that's like couldn't walk across a football field in our description of it. So I would give him a 3, definitely a 3 during this suspected exacerbation.
That's kind of where I thought too. I actually listed him a 3 when I did this. It was a 3, and he was you know, and I guess that's a good way that we could actually go through. So with the first diagnosis part of this was he's a 3 normally on a good normal day. So what if I did the CAT exam assessment? I'm sorry, guys. I have these marked and come in here. So if we said he did a CAT, the COPD assessment test, he actually coughs a little bit and doesn't have a real big production. He's mainly a dry COPD, or he doesn't get a lot of production up with it. He does have limited activity pretty much all the time. And let me go through the rest of it. His chest really never is tight unless his atrial fib is giving him some trouble. So, and that's very rare. He's pretty much stable with that. He can't walk really up any hills or any flight of steps. So if he was going to say that, you'd say he was probably a 5 on the CAT scale there. And he's limited in doing any activities at home. this gentleman, he takes care of his grandchildren, believe it or not, from a chair pretty much in his house. So you'd probably think he'd be a 3 there. And then he still leaves home, I would say at least 50% of the time, either pick up his grandkids from school. And I think that's really what keeps him going. He has this real focus there. And I think that's a good motivational tool for him. He says he sleeps only about 2 hours a night, and his energy level is low. So I actually scaled him out at about 32. So he's pretty severe on that. Now, I don't generally have used the CAT assessment tool on this. This was kind of new whenever I started going through the gold standard, and I actually done that, but it was kind of a something that I found very useful when I started doing this. I thought, yeah, that's a good thing that I needed to do. The other part of this was the ABCD assessment tool. Okay, now if I based him out, I would say he's at least a gold 3, on him. Now he's on triple therapy right now, and he's currently using oxygen intermittently. He probably could use it all the time. He's just real reluctant to use it all the time. Now his chest X-ray, I think Dr. Doyle had already talked about. It had some bullous emphysema. Now I guess the biggest issue is this gentleman hasn't smoked in years, and it's kind of perplexing why that he developed such severe lung disease at such a young age. His X-ray. Did we already look at the X-ray? It's
Yeah.
long. You could count all those ribs all the way down. And he's hyperinflated all the time. So this really made it really kind of a challenging patient. When I first got him 8 years ago, it was a big push to figure out why he was developing COPD at such a rapid rate. And I guess that was the biggest thing that we've never come to 100% understanding of what precipitated this severe COPD. Now in his spirometry, we looked at that and it's pretty severe. His FEV1 is very low. He has a lot of trouble in daily activity, and the spirometry kind of showed that. Any questions? This is kind of I would expect to see this lungs on a guy who smoked for years and at age 70, not at this age. And this has really been the complexity of this case is why is he's developing such a severe rate of COPD at this age.
Chris Tipton, I can't remember if in the case, did it mention his work history? Did he do anything in the coal industry or anything?
No, he was a guy who worked as a fry cook at our local dairy bar for years until he got to work that. So, but he never used flour. I know sometimes and I did have a patient who had got some COPD and restricted lung disease from being a baker, had a baker's lungs, but no, he really never worked with it because, I thought maybe, and then I thought maybe he had some kind of fungal infection, but we were never really ever seen anything, and he's had bronchs over the years, which were all been non-diagnostic.
That lady for the flowers worked at Hardee's, didn't she?
Yeah.
Made biscuits at Hardee's.
Yeah.
So yeah, and her lung, so I don't know what's caused this severe COPD. Can we go to the next slide? So I guess the biggest thing, prevention, I don't know really what we could do to prevent it, since we really don't know the underlying pathology to cause this. Smoking cessation, he smoked for 10 years. That was several years ago. Hasn't smoked really since then. Every time he goes to the pulmonologist, they change his inhalers. So he has trouble actually knowing what an inhaler. He's probably got 30 inhalers at home because every time he goes, he gets a new inhaler. So whatever's new on the market, they put on him. So so he really, and like we'll go back, he'll do this and he can't figure it out. So we'll end up having to go back. So I think right now we're back and forth between Symbicort, and just because he feels most comfortable with those. And you know, really and truly, I think sometimes pulmonology, what they do is they don't know what to do, so they just change inhalers.
And you mentioned he had one genotype
Yeah.
for alpha.
In the chat also, Chris, pardon me, there is a mention of asking, didn't you mention he has alpha 1?
No, yeah. So that's a great thing. He's got an MX, which or an MZ. I'm sorry, an MZ, which means he does have one alpha type. And we thought, well, this was the thing that could have precipitated this 100%. We got one expression on one test of an MZ. Now we've repeated this maybe 5 times over the last 2 years, and they've all come back M&M. So I don't really know. So that's an awesome thing because we think he has alpha 1. Now he got treated for a couple of years after the MZ with no improvement and no response. And truthfully, we had no benefit. So he actually kept progressing over this time. So then they decided to recheck him, and like I said, the last few's become MM. And so I don't really know if that was the first test was a faulty test or the last 4. We never caught that's a great question. I don't know. That's and I put that in there just so we could talk about that because this was the complex part of this case. I really don't know if this guy's truly an MZ. He never has tested for a ZZ, which is a 2 out of 2, but the MZ, like I say, we had one test that we sent to the University of Florida. We used to get these sample things. We would do 3 drops of blood on a card. We would send it out, and this one come back as an MZ, but the other ones we've ever checked, we have never found a full, like I said, the ones come back in MM. So I don't know. I threw that in there because I thought it was an interesting part of this. No, he never served in the military. Yeah, that's a great question. Never served in the military. He's a local guy, and I've known him since I was a little guy here in town. So he's always been a local person. So we do have some long history on him. I've only been taking care of him for 8 years.
I wonder if they used a gas stove. Maybe.
I never asked him, Johnny. I don't know. No, I never asked him. Or and his parents, he never really knew his father very well, and his mother was a smoker up until he was in high school. I do know that. So I guess he got some of that but no history of asthma as a kid, no history of any of that.
What kind of heat they used?
I never asked him. That's a great question. I don't know if he used any heat, what heat he used. I'm not sure.
Or if he grew up in a coal camp.
Yeah.
Maybe.
I'm sure he did.
Yeah, it's from local.
I'm sure. Okay. The methylxanthines, they use this. He's on one, and we've tried it. Really and truly, all I've ever got from using those, he was on that before his atrial fib, and that was something that a pulmonologist put him on that. He's been off of it since his atrial fib, and like I say, he really never had a great response to that, to the medications. And then the phosphodiesterone 4 inhibitors, he's taking Daliresp right now, and he uses that pretty regularly. He says the only thing that really does is cause him to have bowel problems. Can't really, but we're so late in his treatment plan. I'm not sure if we're going to get great results from much.
Yeah.
Now, about a year ago, I had read the gold standard when it first came out, so I put him on Zithromax, 250 milligrams, and we did this for about 6 months. I was just wanting to see if he improved. His hospitalization, he goes in at least 5 times per year with this, and it never truly changed. So at that point, and he really doesn't have a real wet, like infectious kind of cough. So at that time, I just decided we was going to take that off. And then any of the other treatments, sporadically we've tried things here and there with no great results. We have tried to put him in with Johnny for pulmonary rehab several times. I'll be honest with you, his biggest issue is he takes care of these grandkids, and he just is not, he's not super motivated. That's his motivation. And I know that's, and I talk to him about it every day, but every time he comes in, he needs to do this, but he's just not super motivated. And if he's not motivated, I don't know if pulmonary rehab is going to be this. Yeah. And because we've talked to him, Johnny's talked to him as well. And, he's just never really been on board 100% to do it. Any questions about those? Oh, yeah, I see. Going in the house? Yeah, I don't know. Oh, have they made any advancements with alpha-1 treatments? Yeah, so they have. They actually do infusions. But I really think when you read all the literature on that, it says that stuff's really good early on. I think when you get to end stage kind of stuff, I'm not really sure of using that. Now, I guess what we've seen is we use some anti-inflammatories like prednisone in late in all of these the COPD stuff. But as far as when we first started, like say several years ago, we didn't really see anything. But they say that they're really at the end of this. It's not a good thing. Now we checked his son. Interesting side note, his son presented to me with Guillain-Barré syndrome about 6 years ago, and from a flu. And so I took care of him for several, and we checked him for the alpha-1 gene as well as he's got two, and both of them were checked, and we never had a positive alpha-1 in either one of those. So so I'm not sure where the role in that is. Can we go to the next slide? Again, interventional treatment, pulmonary rehab would be a great thing. Lung volume reduction surgery, that's kind of come into favor here on and off for the last 15 years. That having a thoracotomy in someone who's got poor lungs is always a scary thing to do. And so it's one of those things that we just, I've never really been 100% saying I need to send my severe COPD unless they got a bulle that's huge, and I thought maybe that would really help. But a true lung reduction surgery, I'm not seeing great results from, and I've had 2 patients now in the recent 5 years that's had it, and they really didn't do very well. Bullectomy, like I say, just to take out the bullous, where they just go in there and just staple that one section off. In his case, his bullets are not that large. We've scanned him. We've never really seen it. His last CT scan talked about two small bullets. He's never had a pneumothorax, so we never done that. Transplant. We did send him to Pittsburgh one time for a transplant evaluation, and he was going to get on the list at one point, but again, he's not very compliant. He has to go through certain parameters even to get on that list, and he's just not real super compliant with that. Now there is a doctor in Charleston right now doing these endobronchial valves, and I had talked to him maybe about doing some this with him, especially in 2 lower parts of his lungs, to see if we could get an improved function. And I sent him up for that. After he looked at it, he said that it was such a diffuse disease, he couldn't figure out where to put the endobronchial valves to get an improvement. So he actually did a couple of studies, and he bronched him one time and actually tried to put just to deflate one section to see how he'd do, and he immediately desatted. So he was afraid to even proceed at that point. Okay. I'm sorry I got here so late.
No worries. Thank you so much for joining us. Things happen. Totally understand. Dr. Doyle, go ahead.
We're glad you made it. And thank you for working on this, and thank you all 4 of the Southern West Virginia Health Systems people who are with us today. So this patient came with an exacerbation. So one of the things we talked about, Chris, was, what else could it be? And we gave people a mnemonic for that, C3PO4. So in this case, what was it and what did you do to treat him?
Yeah, so when he first, well, he was so ill on this visit, we ended up, we started an IV and we gave him some Solumedrol, gave him a round of antibiotics, and we admitted him. He was at this point, that was really going to be the way we treated him. He spent 7 days in the hospital, and he just got steroids, nebs, and antibiotics for those 3 days. Never had a pneumonia, never any of that. It was all true exacerbation.
Thank you. That's it, Elizabeth.
Awesome. Thank you so much. Really do appreciate all the work you three put into this and everybody that joined today. Are there any questions or comments that anyone would like to make?
Actually, I have one question for the group. Go ahead, Brandy.
I calculated the Bodhi.
That was my question. Way to go.
All right. It's 4 different questions. His walk test was 700 feet, and when that's converted to meters, it's 213. So that would have given him 2 points. His MMRC we decided on was we were just going to give him a 3. So that was 2 points. His BMI, he was really thin. So he actually got a point because his BMI was like below 20 something. And then his FEV1 was 16%. So he got 3 points for that. So his total Bodhi that I calculated was a score of 8. And I think Bodhi's all about just mortality rate, right, Dr. Doyle?
It's for prognosis.
Okay. But I got an 8. Did you calculate it already, Dr. Doyle?
No, I didn't.
Okay.
But for people who don't use that all the time, the top it's from 0 to 10. So
Okay.
not surprisingly, his score was very high, which means, and there is a table, and I don't have it in front of me, that gives you have it there, Brandy, what the 5-year, or it's I think 4-year prognosis.
I think the one that I found was a 12-month mortality of a score between 7 to 10 is 5% chance. 24-month mortality for a score of 7 to 10 is 31%. And then the 52-month chance of mortality is 80% for that score.
Yeah. And one of the things that, pulmonary rehab doesn't change the FEV, any of the PFT parameters, but we do Bodhi pre and post with pulmonary rehab because we can sometimes we definitely see improvement in MMRC, we see improvement in 6-minute walk test, and we see improvement sometimes in Bodhi from like an 8 to a 7 or an 8 to a 6. So thanks, and back to you, Elizabeth. We're done.
Thank you so much. Really great session. Thank you guys. Very interesting. And just if you have anything else you want to add, just please email me. I'll get the recap out later today. Our only announcement is the next session will be April 4th with Dr. Sharma discussing hospital sleep medicine, a game changer. So don't want to miss that. Again, please submit any cases that you have, and we hope you have a wonderful rest of your day.